Good afternoon. Welcome. My name is Alfredo Fontanini, and I'm the chairperson of the Department of Neurobiology and Behavior. I would like to welcome all of you who came in person, as well as our audience that is watching the live streaming of the 25th Schwartz Foundation Mind-Brain Lecture. This lecture is hosted by the Department of Neurobiology and Behavior, and it's generously supported by the Schwartz Foundation. So let me tell you a few words about the Schwartz Foundation. It was created 25 years ago to support and promote theoretical and computational neuroscience. So for those of you who are not familiar, this is a field that is a very cross-disciplinary field, bringing together computer science, mathematics, physics, engineering, statistics, and neuroscience. And the goal of this field is to understand the relationship between brain, behavior, and ultimately the mind. So the foundation was itself a pioneer in creating this field, almost single-handedly really supported and created computational neuroscience. Obviously, I need to give credit, and I want to give credit to the person, the brain and the mind behind the foundation, Jerry Schwartz, Dr. Jerome Schwartz. Jerry is a physicist and an engineer. He was the founder of Symbol Technologies, and he's an emeritus trustee of Stony Brook Foundation. Now, this lecture, the Mind-Brain lecture, was created in '97, and the goal has been from the beginning, and continues to be, to advocate for a computational perspective on studying the brain. The other goal is to bring here at Stony Brook exceptional scientists and speakers who can help us understand the brain and its relationship to the mind. So this year, distinguished speaker, and I'm incredibly grateful that he accepted our invitation, is Dr. Emery Brown. Dr. Brown is the Warren Zapol Professor of Anesthesia at Harvard Medical School and at MGH, where he's also practicing anesthesiology. One day a week, he's a practicing anesthesiologist. He's also the Edward Hood Taplin Professor of Medical Engineering at MIT, where he's also Professor of Computational Neuroscientist. In addition to this dual academic affiliation, Dr. Brown is the director of the Neuroscience Statistics Research Laboratory at MIT. He's the co-director of the Harvard-MIT Division of Health Sciences and Technology, and is the associate director of the MIT Institute for Medical Engineering and Science. Dr. Brown is an incredibly accomplished and groundbreaking statistician, neuroscientist, and anesthesiologist. His contributions span, as you can already imagine from these three fields, multiple fields. His work really revolutionized our understanding of circadian rhythms, brain rhythms, neuropopulations, and anesthesia. He has developed a series of groundbreaking statistical tools and algorithms for studying complex patterns of activity, of brain activity, whether these are patterns of multi-neuron action potentials or all the way up to electroencephalography, EEG. His work has advanced the fields of neurostatistics, engineering, signal processing, neuroscience, and medicine. And in fact, and I think this is a very important point that we want to highlight, Dr. Brown's research has a very significant clinical relevance. He has published, he's incredibly accomplished. He has published more than 300 articles in countless high-profile journals like Science, Nature, New England Journal of Medicine, Neuron, all the best journals in the field. And his work has been cited more than 30,000 times. The list of accomplishments is endless and would take far more than the 5 minutes that was allotted. But it's worth mentioning that he's one of the few scientists who's been elected as a member of all three branches of the National Academy: the National Academy of Sciences, the National Academy of Engineering, and the National Academy of Medicine. He's the recipient of numerous awards. I would like to mention, for pertinence with this lecture, the Schwartz Prize for Theoretical and Computational Neuroscience. He's a fellow of the John Simon Guggenheim Memorial Foundation, and he received the National Institute of Health Directors Pioneer Award. Today, Dr. Brown will tell us about how neural activity during the unconscious state of anesthesia is far from being just an offline mode, but is actually quite rich and very telling us about the brain. So please join me in welcoming today and this year's Schwartz Mind Brain speaker, Dr. Emery Brown from MIT and Harvard.
Great, thank you, Alfredo, for that great introduction. I really appreciate it. It's a tremendous pleasure to be here with you. And I've had a fantastic visit, learning about what's going on, the research and the many areas of investigation that are happening here at Stony Brook. So thanks again for having me. So this is what I'm going to talk about, the dynamics of the unconscious brain under general anesthesia. And I don't know what concept you have of anesthesia at the moment, but the brain is not turned off, as Alfredo was saying. Actually, before I begin, how many people have had anesthesia? See, it's a very pertinent topic. All right. So this is what I'm going to talk about. I'm going to give you a clinical look at general anesthesia. Then we'll talk specifically about three drugs, Propofol, Ketamine, and nitrous oxide. I want to show you what happens to the brain as we age under anesthesia. And also, I want to talk a little bit about the future, like turning the brain back on after anesthesia, and also the idea of closed-loop control. So here are my main points that I want to make. The brain under general anesthesia is dynamic. It's not turned off, all right? And we think that one of the primary mechanisms in which the drugs actually create altered states of arousal is by generating oscillations. These oscillations impair the ability of various parts of the brain to communicate. Because of that, because the oscillations are so strong, they're very stereotypical, you can use it to monitor the brain states of patients under anesthesia. And I'll show you at the end, you can use it to build a control system. And I want to push a new idea, reanimation. We give you drugs to anesthetize you. What we don't do is give you drugs to turn your brain back on. And that's one of the things which we should be doing. And I want to show you some work where it shows that this is very possible. And then just as a final statement, anesthesia is not viewed as a field of neuroscience, it's viewed as a field of pharmacology. And that's been a drawback. And the losses there are to the field of anesthesiology, to neuroscience, and probably most importantly, to patients who require anesthesia, because we're not using the neuroscience as we should be. So we should be thinking of it also as a way of studying the brain. So what is general anesthesia? Well, it's a drug-induced reversible state that consists of antinociception, meaning loss of pain perception, unconsciousness, amnesia, akinesia, so you're not moving around while the surgeon's operating, and physiologic stability. And if you take these first four conditions here without the reversible, then it's synonymous with death. Okay, so that's not cool, all right? So the whole idea is to create a state where pharmacologically, you put someone in this state and you bring them back. And as I've told several of the faculty today in our discussions, it's often said it's not clear how anesthesia works, and nothing could be further from the truth. So that's one of the things we're going to talk about quite a bit today. But just a modicum of history, since I'm from Mass General. So the first public demonstration of anesthesia took place October 16, 1846, by William Morton. Morton was a dentist, and he realized that he could give people a full set of dentures if he could take out all their teeth. So he's looking for a way to take out all their teeth. And dentists, as well as surgeons at the time, were measured, or they were valued by how quickly they could take out a tooth, or a surgeon could do an amputation. And he could take out a tooth in a minute, basically. But 32 minutes to do the whole mouth might be a little hard, essentially. So he came upon ether through a chemist, Charles Jackson. And at the time, people used to keep the ether in little vials at home, and then after dinner, they'd sniff a little ether, to kind of feel good afterwards, So he realized, he saw someone do this at one point and pass out, and he reasoned that he could use this as a way to mesmerize someone for surgery. So he proposed this idea to John Collins Warren, who was a surgeon at Mass General at the time. And And so on October 16th, 1846, in the Ether Dome, which is the amphitheater in the Bullfinch building at Mass General Hospital, they undertook a surgery when this patient, Gilbert Abbott, who had a tumor on his neck. And so Morton built these really cool flasks. You can see them in the MGH museum with a sponge inside soaked in ether. He held the flask up to the patient's face. He inhaled it. And then he said to John Collins Warren, "Your patient is ready." The patient had passed out. He performed the surgery. John Collins Warren performed the surgery, and the patient came to afterwards. And John Collins Warren said, "This is no humbug." That's 1846 speak for "this is no bullshit, it really worked." So the name for the process came about 7 or 8 days later when Morton wrote to this second gentleman here, Oliver Wendell Holmes Sr. He's the father of the Supreme Court Justice. He was like a great thinker, sort of a very learned man, as was referred to, because he had studied in Europe. And he's the one who came with the term anesthesia. And he said lack of sensation, and noun would be anesthetic. And he actually pondered several different terms to use. But that's where the term came from. And he said that it should, so whatever term we pick is going to be with us now and, and on into the future. So that's what by way of history. So what do we actually do for you? We actually do what's called balanced anesthesia. We use combinations of drugs to create the state. We first induce by giving something like Propofol to make you unconscious. We keep you unconscious by maintaining Propofol as an infusion, or we use one of the inhaled drugs. And if you look here, you see how I have inhaled drugs in every category there? The inhaled drugs are ethers. We still use ethers after more than 175 years. So in that respect, we haven't made much progress at all. And so what we found is by using combinations of drugs, as opposed to just using a single drug, you can get most of the good effects and fewer of the side effects. Because you could do the whole thing with just essentially the ether, but basically you'd have tremendous side effects, depression of the heart, vasodilatation, things which wouldn't be good. So let me give you a look at what anesthesia is like. This is a little video I like to play to sort of start my talks. So this is from a woman I took care of. Well, it's been almost 10 years ago now. She's going to have thyroid surgery. And she weighs about 80 kilograms. She's in her 60s. I'm going to give her a bolus of Propofol, one of our most used anesthetics. The anesthetic is associated with Michael Jackson's demise. I'm just going to play the video here. So I just injected the Propofol. And watch her EEG. So she has 4 leads of EEG, 2 leads on the left, 2 leads on the right. Those are eye blinks. Now watch what happens. It's going to get very noisy here for a second. Watch it get very noisy. Because when you inject Propofol into a small vein, like the one on the back of my hand, it burns like crazy. So she's going to do this. She's doing this. See, it's getting noisier. Now that's actually good from a pedagogical standpoint, because as soon as the drugs take effect, you're going to see it very clearly. So give it about another 10 or 12 seconds here. So that's her tensing up, tensing up. And watch what happens right here. Beta oscillations, she's sedated, slow oscillations. She loses consciousness right here where these slow oscillations come on. And now watch this, she's gonna go flat, and then burst, and then flat, and burst. So she's completely out. So what did I just show you? That's her awake. So about 5 microvolts in the EEG. So the high frequency oscillations, very irregular. And we saw her go next to this state, the sedation state. So this is what we call beta oscillations. So they're somewhere about 14, 15, 18 hertz or so. If I wanted to give her anesthesia so she could tolerate a colonoscopy, I would titrate the drug and hold her in this state here. And she'd be somewhat sedated, maybe responding to me, maybe not remembering, that sort of thing, all right? But we saw her go right down here to state E, which is the slow oscillations, or just very, very large slow oscillations. And this is a sign that the drug is having effect primarily in the brainstem. And because one of the things that happens when you sever brainstem connections from the projections going up to the thalamus and the cortex, you actually generate these large slow oscillations. There are other contributors to them too, but this is the one we see here is probably just that. And then we saw her go into burst suppression, a very deep state of anesthesia, far deeper than she really needed to be or needs to be. And we also see this sort of brain state in patients in coma and also in patients with traumatic brain injuries. So just to show you how powerful the anesthesia is. And you saw she got there literally in less than a minute. And then the isoelectric state, between the bursts, she's actually flat. This state here is the one we're going to talk most about, where you have a combination of slow oscillations like this, and then high frequency alpha oscillations like that riding on top. That's a state where she's sufficiently anesthetized so she can tolerate surgery and will be unconscious, but not so much that we're overdoing it. And the paradox excitation, we'll come back and speak about that at the end. Because it turns out that just like as you take some drugs to get a high, low doses of anesthetics often produce a high too. That's why it's called paradox excitation. Something which is supposed to sedate you actually gives you a buzz. We'll talk about that with nitrous oxide. But this is what the picture looks like in the operating room. So this is a young woman I took care of a few years back. She's 19 years of age. I was using an infusion of Propofol. So right here where the line is, right here I gave her a bolus of Propofol. This is a spectrogram. So what we're doing is we're taking the signal and breaking it down into its components by frequency. And so initially, she had the slow oscillations, just like we saw with the woman in the video. And then she goes into this pattern here, where you see the slow oscillations about 0.1 to about 4 hertz, along with the alpha oscillations, which are around roughly 8 to 12 hertz, 10 hertz. This is a classic pattern of Propofol. You give Propofol to a young person, you maintain an infusion, you're going to get the slow delta oscillations, 0.1 to 4 hertz, and then the alpha oscillations, 8 to 12 hertz. And as long as you keep the infusion running, I had an infusion Propofol running, I turn it off, it breaks up, and she woke up over here. So this is classic Propofol. I want to give you some idea of how these oscillations essentially come about. So these are my colleagues that I've done this work with. Patrick Purton at MGH, Shenung Ching is now at WashU. Nancy Gopel, we're very well-known computational neuroscientist who's at Boston University. Ahmad Eskandar, neurosurgeon. Eric Pierce, anesthesiologist at MGH. Laura Lewis is now in the faculty at MIT, and Sid Cash, neurologist at MGH. So this is what we see in the operating room, all right? And this is not an enhanced figure or anything like that. The spectrogram, this breakdown by frequency, is just this clear on the monitor in the operating room. So it's very easy to read. And how is this happening? So one of the things that Propofol does is it enhances GABAergic inhibition. Now, GABA is everywhere throughout the central nervous system, but there are 3 main places in the brain that I just want you to keep in mind. One is up here in the cortex, where you have the interneurons, which are controlling large numbers of pyramidal neurons. Another very important place is right here, the reticular nucleus of the thalamus. Remember, the thalamus is like my fist, and the reticular nucleus sort of covers it. And the key thing is it's inhibitory. So every excitatory, every output going up to the cortex, coming out of the thalamus gets modified or somewhat dampened down by the reticular nucleus of the thalamus. It's the GABAergic site. Then this other site I want to point to right here. See where it says POA? So the POA stands for preoptic area of the hypothalamus. It's like my wrist. My fingers are the projections coming out of it. And those projections are GABAergic. And so you've got these 3 main sites in the brainstem, around the thalamus, and the cortex where the Propofol could act. And what happens on induction, here I'll just describe it for you. So the Propofol hits the brainstem by coming up to the basilar artery, which sits right here where I'm passing my arrow. And it gets this location here, and it sees all these inhibitory sites, and it goes, wow, cool, inhibitory sites. And it just goes to town, boom, 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 boom. And that's when you saw those large slow oscillations come on. That was the Propofol acting primarily at those sites. But the blood flow is very fast, so it's also getting to the thalamus. and it's also getting to the cortex at the same time. And the one thing which I didn't tell you is that if you look here at the alpha oscillations, these alpha oscillations are concentrated primarily in the front of the head. And so one of the things we figured out initially, thanks to modeling with Nancy Coppell, is that those alpha oscillations go back and forth between the thalamus and the cortex. So if you think about it, if you wanted to tie up one brain region, you only had one, you said you wanted to tie it up, the thalamus would be high on that list to produce unconsciousness, because everything goes through there. Visual information, auditory information, somatosensation, proprioception. So the propofol is creating this oscillation between the thalamus and cortex, taking it out of that normal sort of gamma rhythm and making it very difficult for the thalamus and prefrontal cortex to communicate properly. So we did this first by modeling, but then we subsequently did experiments in rats to sort of prove this idea. But let's look at the slow oscillations. So these are some of the best human data that I have on what happens to the brain under anesthesia. So on the left here, you have a patient that's conscious. So these are patients who come for epilepsy surgery. And so they get electrodes implanted, they have treatment-resistant epilepsy, so they're going to need a resection of an epileptic focus. They get electrodes implanted, they stay in the hospital for 5 to 7 days off of medications, and then they come back to the operating room to have the electrodes removed, and then eventually they have a resection. So when they come back to the operating room that second time, you have a very amazing natural experiment. You have a human brain that has electrodes in it. So you can see what neurons in the human brain are doing under anesthesia, and also field potentials. So that's what I'm showing you here. So these are field potentials recorded from the surface of the medial temporal lobe here on the brain below. And over here, this is what the neuron sitting next to that red electrode is doing. It's spiking pretty much wherever it wants to. Now look what happens here once you give it propofol and the patient is unconscious. So look at the large slow oscillations. So now it spikes like this, now, like every 2 seconds. So I would submit it's going to be very difficult to be conscious if that's the rate at which your neurons can now communicate, right? So you can see the slow oscillation is a very strong indicator of when someone is unconscious. But let me just refine that a little bit further. So we were able to do the same experiments in non-human primates with Earl Miller, Andre Bastos, who was one of his postdocs, and Jake Donahue, who's our PhD students. These are data from Jake's thesis. So we did the same experiments in non-human primates, but now we can put electrodes in 4 areas. So the first one is area 8A is the frontal eye fields, PFC is prefrontal cortex, PPC is posterior area, posterior parietal cortex, and the superior temporal gyrus, the auditory area. So here's the animal, non-human primate awake, and here are the neurons in those same areas spiking. So let me give you a quantitative feel for this. So the neurons are spiking at about 10 to 12 spikes per second, right? When the animal's awake and consciously doing some sort of activity. Now look over here. The animal's unconscious. There are those large slow oscillations. Now look at the spiking activity. Even when the neuron is spiking, the spike rate has gone from 10 to 12 spikes per second down to a half to 1 spike per second. So about a 95% drop in spike rate, all right? So, and look, you can see the large periods when there's essentially no spiking. These are the up-down states. Okay, so why does this matter? Let's just go back here. If anything that I've said is correct, or approximately correct, about the slow oscillation here, or the alpha oscillation, you can understand or have at least some insight into why someone would be unconscious. So if that's what's underlying these oscillations here, then an anesthesiologist can use this in the operating room to track the state of a patient under anesthesia. And the reason I make this point is that using the EEG, as I'm suggesting here, is not standard of care in the hospitals in the United States. In fact, in our own institution, only about 28% of our anesthesiologists use it. It's about the same number basically across the country. And it's just a habit of the way the practice has taken place. This is something we're trying to change. So that's Propofol. So let's turn to ketamine. Ketamine is really cool. So if you give a low dose of ketamine, here's an EEG signal coming from ketamine. This is work done by Indy Garwood, one of my PhD students, Suresh Chakrabarty, who's one of my postdocs. So here's ketamine. If you give a low dose of ketamine, you actually get the EEG speeds up, all right? It doesn't slow down, it speeds up. And the reason it speeds up is that for ketamine to work, it actually has to get into the channel. And relatively speaking, the inhibitory interneurons are working more than the pyramidal neurons in general. So at low doses, you're going to take out the inhibitory interneurons first. I didn't say it, it's an NMDA antagonist. So it actually blocks the NMDA receptors on inhibitory interneurons. So you inhibit the inhibitory neurons, the pyramidal neurons free up and become more active. Then when you give a large enough dose, you actually take out the inhibitory neurons as well as excitatory neurons. When you give a large enough dose to take out the inhibitory neurons and the excitatory neurons, you get this really cool pattern where it goes fast and then slow, fast and then slow. You can see it here in the spectrogram. It goes fast, slow, fast, slow. This is actually a human anesthetized with just ketamine. You see this sort of back and forth between these two patterns. This is entirely different from what Propofol is doing. And as I was just saying, Propofol or ketamine is an NMDA antagonist. So there are these very important glutamatergic pathways which come out of the brainstem going to central thalamus, going to basal forebrain, which are probably the major targets that are producing this effect, all right? Deciphering this, but why it happens every 4 to 10 seconds is something which we're trying to work on now with our modeling. We have some ideas, but we haven't totally refined it. But this is a very robust phenomenon. So we repeated the experiments again in non-human primates, just like with the Propofol. And so you can see down here, see all the slow oscillations here, see the faster oscillations here. If you take this little segment of the graph right here and blow it up, here it is blown up. You can see it goes fast, slow, fast, slow. But actually, it's actually more subtle than that. You go from slow, a little bit faster, then fast. So you go through about 4 or 5 states as you transition from the really fast pattern to the slower pattern, and vice versa. So this is something which we're working on to really understand the dynamics of. But this person is profoundly unconscious. And it's an entirely different dynamic from what I just showed you for Propofol. And when you look at the brain regions together, so this is looking at them across the entire cortex, the 4 regions. So 50% of the time, all of the regions are perfectly in sync. About 70% of the time, the 2 posterior regions are totally in sync. And then about 80% of the time, the frontal areas are in sync. So this creation of these very rigid, structured oscillations, even though, and I didn't mention this, but the spike rates on average are the same the whole time. Nothing has changed. You're just changing the dynamics of how the parts of the brain can communicate. It's going from very fast to slow, very fast to slow. This also produces unconsciousness. And that's the unconsciousness of ketamine. So I had to put this in there because Ezra Marcus, who's a writer for the New York Times, called me up a couple of years ago and said he was going to do this article. And he read this paper we'd written about nitrous oxide. You know, this has become a fad again, you know, sniffing nitrous oxide, like whippets or that sort of thing. This is dumb. Do not do this, all right? It's not a good idea, all right? But this guy here is like, basically, he's giving himself, he's self-anesthetizing. And just to put this in the context, when we have little kids who you can't put an intravenous line in, this is how we anesthetize them. We actually give them a mask of what's combined with nitrous oxide with Isoflorine, let's say, and have them take a deep breath. And in a single breath, they can take themselves out. And then we go ahead and start working on putting in the IVs and all that sort of thing, beginning with the surgical care. So these people could do exactly the same thing to themselves. This is extremely dangerous, all right? And when I show you the oscillations of what their brains look like under deep nitrous oxide anesthesia, you'll see why. So this is your brain on nitrous oxide. It's that same EEG that I was just showing you I used in the video. the 4 leads that I'm measuring. And just to put this into perspective, each one of these vertical lines here is a 1 second. So you actually have a perfect 2 hertz oscillation taking place. There's no noisiness whatsoever. This is probably not compatible with being conscious, but not only that, if it's too deep and no one's there to revive you, it could also be incompatible with life, right? And so here's how we do it in the operating room. We actually very often switch over to nitrous oxide at the end of the case because it's easier to wake someone up. So here's the isoflorine, which is, it's on here. So this is the isoflorine pattern. You start the nitrous oxide, and it takes it a while for it to take effect. But you can see how the spectrogram here is changing. Then all of a sudden, you get these very large, slow oscillations. These are these guys here, and that's that. What's really interesting about this is that they don't persist. They stay there for about between 6 to maybe as long as 20 minutes. Then they dissipate altogether by themselves. And you get these high frequency oscillations like I'm showing you here. And that's what this is. So again, part of the mechanism of this we think was also NMDA blockade. We probably won't be studying this further because nitrous oxide is not a friend of the environment, let me just put it that way. So we're pushing more towards studies in intravenous drugs. But this is another pattern of unconsciousness, which is profoundly different from propofol, different from ketamine. So this is what I've been sort of showing you. If you look at the EEG of patients on the different anesthetics, you can probably see the differences among these different drugs. But you can see the differences better if you look at the spectrogram right here. And so this is one of the things that we've been trying to encourage anesthesiologists to do, to use these to help basically take care of patients in the operating room. And we've created a free website so they can learn how to do this, you know, and use the monitors and more accurately dose their drugs. And what I've been trying to suggest is that these oscillations are not epiphenomena, but they're part of the mechanism through which the drugs are producing the altered states of arousal. So we can go back and do a deep dive with each one of the different drugs and describe how it produces the oscillations, some of which we've done just modeling, some we've done both modeling and experimentation. If I leave you with nothing else today, general anesthesia is not sleep, okay? It's very often an anesthesiologist approaches the patient, they'll say, Mr. Jones, I'm going to have you go off to sleep for your surgery. I mean, you can't go and say, Mr. Jones, I'm going to put you in a drug-induced reversible coma, but don't worry, I can wake you up, right? The patient's going to hop up off the table, right? But what I say to my patients is, I just say, look, you're going to be unconscious, you won't be aware of what's going on, you won't have any memories of what's going on, you won't be moving so the surgeons can operate, and I'll watch your heart rate, blood pressure, and temperature, and I'll take good care of you. I give them the definition of anesthesia. Trying to use it as a metaphor for sleep is a bad idea. And in fact, it's important to realize most of the sleeping medications that are out on the market, like the benzodiazepines or whatever, if you call them weak anesthetics or sedatives, that's actually a more accurate statement because they bring you into one of those anesthetic states that I showed you before. And here they are over here. And also, but just thinking about the difference between sleep and anesthesia. So these are the awake states which I was talking about. And when we give you anesthesia, we bring you down and keep an infusion going or give you gases so you come down to one of these states here. So the brain is doing this. It's in that state. And as long as you keep doing that, it just stays there. And what's sleep? I mean, we all know this. Basically, you go back and forth between two states, between non-REM, like this, and up to REM, non-REM, up to REM. You do that about 4 to 6 times a night, roughly every 90 minutes or so. We typically wake up from REM sleep. That's when our brain is most active. We're probably dreaming. And then during slow wave sleep is when we have most of our rest or what have you. But that's a totally different state. I'm just sitting there with the brain oscillating like this. And for, like the tragic situation that occurred to Michael Jackson, it's very clear that this was not the way to try to sleep. And it turns out we have anesthetics which actually are better at producing something approximating slow wave sleep than what's on the market now. And you should see more about see more of that coming to fruition in the next few years or so. I just want to tell you a little bit about the brain with aging. So Laura Corneliuson, who is at Children's Hospital along with Chuck Birdie, Shiona Keiju, who's at Mass General Hospital, he's now our new chair of anesthesia. Shangyun Kim, who's one of my postdocs, who's now back assistant professor back in Korea, and Patrick Purton, who's at MGH. So let's look at the brain response as a function of age. So that's Propofol. You're experts on that now. 10 hertz oscillation, slow delta oscillation, 30 years old. That's exactly what you'd expect to see. So here's someone who's 57. Same pattern, you can see it pretty clearly. The oscillation has dropped down a little bit. It was around 10, now it's a little lower. It's about between, about 8 to 10. It was higher, between about 10 to 15, now it's about 8 to 10. And you can see it's a little more faded, but it's very clear there. Clear alpha oscillation and the slow delta oscillation is there as well. Now, here's someone who's 81 years old. So this is a woman I took care of who had a tumor on her chest the size of an American football. It took the surgeons the better part of 6 hours to remove it. But I was able to give her 1/3 of the already age-adjusted dose of anesthesia because I was watching her EEG. I was able to wake her up on a dime. Now here's the part which is sobering. These two guys are the same age, roughly speaking. His EEG looks like his, and his EEG looks like hers. So when you first see this, you go, wow, what's going on here? This is kind of wild, or this is weird. Well, we age different physically. It makes sense our brain age differently as well. But what's interesting about it is anesthesia makes it show up, or could make it show up, because what does anesthesia do? It amplifies everything. It does this. So if you have a youngish brain, you can do a lot of amplification. If it's not so young, it maybe doesn't amplify as much, so you don't see the oscillations there. And these changes that we're talking about with aging, we don't have to invoke anything like Alzheimer's or that sort of thing. Just think about a neuron. A neuron has a myelin sheath, which breaks down over time. The cell volume declines. The dendrites don't work as well as they used to. You don't produce as much neurotransmitter. So all of these things make it so that the neurons, as they transmit the electrical signals, become less faithful cables, as you might think of it. So that's what we're seeing with the aging brain. You can probably guess what the kids look like. So there's a 3-year-old, all right? And there's a 14-year-old, all right? You can, and as I said, these aren't enhanced. It looks like this basically in the operating room. And you can see that one of the things that's been done, people have built indices based on people in this age group, to try to track the state of anesthesia. These indices haven't worked very well in 2 cases, which you've already seen. They don't work well in ketamine, because instead of slowing down, things speed up. And they don't work well in young kids, because according to the index, you're not supposed to have any power up here. And look at it, the young kids, the power is like enormous. In fact, the power is actually the highest in kids who are like 6 to 8 years of age. We don't have any really, that's just an empirical observation. And then it declines over time, basically, with that. So all of you, you 20-year-olds out there, don't get smug. Yours is declining also, too. So, the same way. But there's a very systematic change with age in the anesthetic state. So when you use the EEG, you have to be able to take these things into account. But it's very simple to do because these are well documented. I want to tell you about some work from my colleague Ken Sull. So back in 2011, the New York Times did a piece on our laboratory. This is one of the letters that came in from the editor. I had my first corrective surgery for infantile paralysis, so that's polio, in 1949. The bill for the anesthesiologist was $400. My mother was horrified, but my father calmed her when he said it was probably $50 for the procedure, but I gladly paid $350 because he knew how to wake her up, all right? In fact, I hear this all the time. You go to a party and people say, oh, you're an anesthesiologist, you knock people out. I go, no, any fool can knock you out. I bring you back, all right? So, but we don't actually bring you back actively. We just turn the drugs off and let things wear off. And from what I've just told you thus far, your brain for 4 hours is doing this under surgery. And to think that it's just going to pop back and be normal makes no sense. So why not help it come back? And so these are some experiments that Ken's been doing. I'll show you one which involves some electrophysiology. So he has a rat here that's anesthetized with propofol. He has propofol running into an IV in its tail vein. And what he's going to do is stimulate his VTA, his ventral tegmental area, top of the midbrain arousal center. I'll show you the anatomy of it in a second. He's going to keep the propofol running and watch what happens to the animal. So no stimulation. Now watch right here. When he turns the stimulation on, watch what happens right there. So he starts breathing like crazy. The propofol hasn't been turned off. It's still running. The propofol is still on. He said, I'm out of here, Ken, I'm leaving, all right? All right? So what's Ken doing? So before I tell you what Ken is doing, I want to share with you what I call science from the word on the street, all right? This was also in the New York Times back in 2015. This woman had this startup company, and her investor said, we want a new financial plan on our desk first thing in the morning. So she goes, ugh. So she calls up her drug dealer. He comes over, brings her a bag of pills. She gives him a wad of money. She gulps down one, then she takes another one. And she says, I felt my brain like snap to attention, all right? So she started working. She worked for 7 hours straight, slept for 2 hours, and went to deliver the financial plan. So this is what people are doing quite a bit, self-administering drugs like Ritalin or some of the amphetamines, because it makes their mind sharper when they're on their drugs. This is dumb. Do not do this, all right? Because the drugs are also, they're stimulants, and they can also cause some pretty severe cardiovascular problems. But on the street, they're telling us one way to sharpen up your mind is to use drugs like this, so why don't we use them to turn the brain back on after anesthesia? So that's what we've been looking at. Now, you saw the rat in the video. He got up and walked away, but is he functional cognitively? Can he actually do something? So Ken did another set of experiments, which he trained the rat to do a task. It touches the correct light, it turns around and gets a reward. It touches the correct light, it turns around and gets a reward. So now what he does is he combines the experiment. He puts the animal in this chamber, anesthetizes it, then wakes it up. When it wakes up, he goes, oh, I'm in the performance chamber. If I do the task, maybe I'll get something to eat. So it starts performing the task. Then now, he wakes the animal up by stimulating the brain, but he doesn't turn off the anesthesia. Then what he's going to do is he's going to turn the stimulation off, and the animal's going to go back out. So let me show you this. So there's the animal. He's anesthetized with isoflorine. He's out. He has a stimulating electrode in his ventral tegmental area also. Ken's going to turn the stimulation on now. He comes to, remember the isoflorine's still there in the chamber. He looks for some food, but there's no free lunch. He's got to hit the correct light first. So he hits the light, turns around and gets the food. So he's cognitively processing. That's the point we're making, all right? So he turns around again, a little wobbly, hits the correct light, gets the food. Remember, the anesthesia is still going, all right? Now he turns around this time. I think he gets this one wrong. Yeah, he got that. So the light tells him it was wrong. So he won't get a reward this time. Now watch what happens here. He's going to turn around and do the task one more time. He's going to turn around and do the task. And Ken turns off the electrode. And he's back out. So we're controlling his level of arousal, all right? And that's where we really want to be, being able to do that, turning it on just as much as we want to, turning it off just as much as we want to. So what have we been doing? So let me go here first. So Ken has been stimulating this ventral tegmental area. So it's part of the midbrain cortical pathway. And it goes, we usually think about this pathway in terms of reward. This is also very important for cognitive processing, right? And it releases dopamine. So when he gives Ritalin in some of his studies, he's actually activating this pathway also. It goes through the limbic system on up to the cortex, or the mesocortical pathway. But what I've been showing you, the studies he's done electrically, we've also done this optogenetically. He's done it optogenetically by stimulating specifically the D1 neurons, right? So this is an arousal, this is a pathway which could be used to wake someone up from anesthesia by using a drug like Ritalin or also amphetamine. So one final idea. So if the markers that I've been telling you about are as good as I claim, we should be able to build a control system. With a control system, you could just sort of automate part of the anesthesia. So, for example, just to give you an analogy, if you're going to fly from here to Tokyo, the pilot, basically does the takeoff, the pilot and the co-pilot. Then once you reach the cruising altitude, you let the autopilot take over. So if we know we're going to have a surge that's going to last for a few hours, why not let an autopilot control the anesthetic level? So this is just a simple control system that does that. So here you start. You start with a marker of unconsciousness, and you have a target. The controller compares the two and adjusts the infusion rate of the propofol going to the monkey roughly every 20 seconds or so. And it gets a new estimate of the marker. MOU stands for marker of unconsciousness, and it repeats the cycle. Just a very standard control idea. But let me just show you the modicum of neuroscience we use to set this up. Use a propofol infusion which is continuous, like this one here, all right? And then remember I showed you that when you do that, the spike rates go down. And we know that spiking, decreasing like this would be synonymous with the brain being turned off, being quite unconscious. So it tracks very well with the power in the LFP or the EEG between 20 and 30 hertz. So if I can track and control this, basically, I'm controlling the spike rate, which is going to control unconsciousness, essentially. That's the idea. So let me show you this in a video that Suresh made. So he's going to set the target to be 1. It's a normalized version of this marker. Then here's the infusion rate down here, which he's going to set it to be constant, first of all, like we do in the operating room. And then we're going to turn and let the controller take over. So let me just play this. So right now, the infusion rate is constant. You can see it right there, it's constant. And the marker, instead of being right at 1, is moving all over the place. Now, after about 40 minutes, he turns the controller on. The controller locks it in and holds the marker right where we want it, right at 1. Now what he's going to do is take it a little bit deeper. So the time on the x-axis is in minutes. Takes them deeper. And now he's going to take it to a less deep level. Moves it up. So this is totally feasible just by generating, using the neurophysiology I've shown you, and also a little bit of simple control theory. I want to make a very important point right here. This is a constant infusion of propofol. This is what we do in the operating room. All right. What is happening when that happens? Look right here. Constant infusion of propofol, the patient just gets deeper and deeper and deeper. It's not surprising. And what did the controller do as soon as it took over? It said the person is way too deep. It actually shut down for 3 minutes. Then let the propofol infusion come back on, and then it started its control. And did a similar thing over here for about 8 minutes. So this closed-loop control is very possible. So this is a system which we're trying to push to a point where we can actually test it in humans. But it should be it should be extremely feasible. So what I've shown you is the brain under general anesthesia is dynamic. It's not turned off. I've shown you the mechanisms through which the drugs act is probably generating oscillations, which impair how the various parts of the brain communicate. And there are different sorts of patterns or dynamics for different drugs. The one for propofol is different from the one from ketamine, which is different from the one for nitrous oxide. And because of this, you can actually monitor, you can see these oscillations very easily in the EEG, use it to monitor the state of the patient under anesthesia. But these states change very systematically with drug, with age. They can also change very dramatically with patient's state of health. Like I said, we should give drugs to do something to turn the brain back on after general anesthesia. Because one of the big problems that we have, kids, 25% of kids will wake up delirious if you use the ether anesthetics with them. And most older patients have some form of brain dysfunction after anesthesia. It's more the rule, I would say, rather than an exception. So turning the brain back on seems like a very good idea to help combat this cognitive dysfunction. And anesthesia should be used more as a paradigm for brain research. So you've seen the New Yorker cartoon where you have New York and the rest of the world. So this is anesthesiology, and this is clinical neuroscience, which revolves around us. But it's actually the case in the sense that there are all these very rich connections with all these areas of neuroscience which we don't take advantage of. So for example, we all know that ketamine can be used to treat depression now. Ketamine is also a very potent analgesic, but it's also has been a model for schizophrenia with epilepsy. At low doses, methotrexate, which is a barbiturate, will actually induce a seizure, but at higher doses it can actually use to facilitate a seizure. And right here, locked-in syndrome. I can give you a combination of drugs right now that'll generate a locked-in syndrome. You'll be apparently wide awake. You'll be apparently, unconscious, but actually wide awake under it. And that's just because of the antidopaminergic effects of many of the opioids and also the butyrophenones. And one of the things that we're studying is, I showed you this idea of using a drug like Ritalin, or suggested a drug like Ritalin, or perhaps some sort of brain stimulation to help foster coma recovery. So we actually have a protocol ongoing now at MGH to enhance coma recovery using brain stimulation. So there are all these ideas that if we took anesthesia more seriously from a neuroscience standpoint, we could improve anesthesia care. We could also connect better with other fields of clinical neuroscience. And overall, patients would benefit from that. So I'll stop there. Thank you very much.
So we have time. So first of all, thank you so much for
My
the
pleasure.
great lecture. We have time for a few questions. So if anyone has questions, can walk to the microphones, either on that side at the end of the stairwell or on this side. Thank you.
Thank you very much for the lecture. I wonder if you could discuss the difference between anesthesia and analgesia. You just mentioned that in anesthesia, Propofol doesn't allow nociceptive signal to get to the brain. So the signal still comes, but it doesn't get through to the brain. What about an analgesia, for example, with opioids or some such drug?
That's a great question. So back in the late 60s, it was figured out that you could use high-dose opioids to do cardiac surgery. Because one of the things that it did was it made the cardiovascular system really stable and made it much easier for the surgeons to operate, for the anesthesiologist to control blood pressure, heart rate, and that sort of thing. All right? But in those cases, they had a number of incidences of awareness. The people there was anti-nociception, there was no pain processing or perception, but they were conscious of what was going on. So that's why what's important in talking about anesthesia, and to be technically correct, analgesia is the control of pain which can be perceived consciously. Anti-nociception, which I put down here, means the control of nociceptive signals when you're possibly unconscious. So that's the difference. So you need to get all of this here for someone to be under general anesthesia. And so if you leave one of them out, we can cite cases where there are consequences of not having it. And the cardiac anesthesia case is one of the best examples, because the opioids are nowhere near as powerful as the as the GABAergic drugs, as far as depressing the cortex, really making you unconscious. They affect some projections which come out of some of the midbrain structures going to central thalamus, but they're very weak effects. So you can be quite conscious then, have great analgesia, anti-nociception, but be wide awake.
Is there any way to determine before one goes under anesthesia whether that patient has an old brain or a young brain, and what difference does it make to the anesthesiologist in delivering?
No, that's a fantastic question. I think that there are a number of studies going on now, both at our institution as well as like at WashU and also out in UCSF, where they're looking at getting a sense of people's, just to use the terminology that I put over here, kind of their brain age, so to speak, and understanding what their brains are likely to be like. I was telling in the faculty discussions earlier today that I think that what you have to do is you assume that everybody's at risk and you use the same caution with everyone. So monitoring, and if I had my way, I'd be able to use a closed loop system and I'd turn the brain on, but it starts with monitoring. You've got to monitor the brain, first of all. Now, there's going to be, if you need surgery, there are very few things that we can do right now to sort of make your brain automatically healthy, so it could tolerate anesthesia better. So the onus is on the anesthesiologist to make his or her care of the patient better. And for the moment, the main thing that they can do is monitor, but not only monitor, you have to adjust the dose of the drug during the monitoring, so you only give the person exactly what they need. That's what I did for that 81-year-old woman. I mean, like I said, I gave her 1/3 of the already age-adjusted dose. So I think so even if we have all this data that says this person's at risk, the tools that we then have to modify our practice are actually quite limited. I was telling folks earlier today, we haven't had a new anesthetic drug in 30 years. That's why we need neuroscience to help push this forward.
It seemed to me that in the earlier part of your talk, where you discussed the responses to the different anesthesias, the information that you presented did not require any technology beyond what we had in the 1980s. So why is this stuff all so new?
I mean, that is a fantastic question. So what's new about it is it was sitting there. In fact, it's even worse than that. The EEG has been around since 1929. And actually, I could show you a figure from an article in 1937 where people said you could use then the EEG to monitor the brain under anesthesia. Right? The key part is that anesthesiologists don't use the EEG and they don't think of the brain under anesthesia as a neuroscience question. Think of the question in pharmacology. So the perspective is, do I have enough drug in the case of the gases in the lungs so the person is anesthetized, right? So us going back, maybe starting about 10 or 15 years ago and started using the EEG very systematically to understand the patterns. From the patterns, we're able to start and talk about mechanisms. All that's actually quite new. Thinking about, how to understand the mechanisms. But then the capacity to monitor, as you said, has been there for years. And it just has not become part of practice. And even now, as we try to push for it to become part of practice, we get a lot of pushback because my colleagues will basically say, I've done this for 30 years already, why do I need to do this? What's the benefit? And what I've seen is I've been able to design whole new anesthesia paradigms to more carefully titrate the drugs using the EEG and also by more carefully monitoring the nociception at the same time. So it actually would change practice quite a bit. But again, the ideas are old. But it's old, but nobody's taking time to really study it systematically.
Okay. Thank you so very much.
My pleasure. Thank you.